Alright, we're going to talk about the infectious process for the first part of our integumentary and infectious disorders. The infectious process consists of several different stages of the infectious disease. The first stage you have is what's called the incubation period, and that is the time between the invasion of an organism and the actual onset of symptoms of the infection. Then you move into what's called the prodromal period, which is a time of these kind of non-specific generic symptoms. Typically what you see like lethargy, maybe a low-grade fever, fatigue, into very distinct disease-specific symptoms like a rash. And then you move into what's called the illness stage, and that is during which those specific symptoms occur. And the last stage that we have of the infectious disease process is called the convalescent period. And that is the interval between when symptoms first begin to fade and when the child returns back to their normal, healthy baseline. And then you also have what's called the chain of infection. Basically, how does somebody become infected? Right? So we have what's called a reservoir. That's the container in which, or a place in which an organism grows and reproduces. That could be a person, that can be an object, that could be a counter space, an animal, an insect. It's whatever is basically holding or carrying that particular organism. And you have a portal of exit, which is your route of which the organism leaves the infected child and spreads to others. So there's lots of different ways you can see those listed there. Then we have our means of transmission. Our means of transmission refers to whether the infection is spread by direct or indirect contact. Direct contact is skin to skin, where indirect contact is usually by fomites, inanimate objects that are soiled. Most common means of indirect contact, usually through mouth and nose secretions. And then you have your portal of entry. Your portal of entry just refers to how did that organism or the pathogen enter a susceptible individual's body, so another child. Was it through inhalation, ingestion? Was there a break in the skin from a bite, abrasion, like a cut or a burn? And then, of course, you have your susceptible host, which, since we're talking about pediatrics, the child that is susceptible to an infection. There's lots of different characteristics that can make someone more prone to infection than someone else. To name just a couple: age, gender, your body defenses as well. Right? So also review kind of health promotion and risk management. Our primary prevention of disease is by use of immunizations, right? By using immunizations, we've certainly cut back on the amount of communicable diseases that we have seen. Although, what have we been hearing lately in the news of what's the most recent communicable disease that we're seeing a big outbreak of? And that's the measles, right? Because of being under-vaccinated, or some of it is playing into that anti-vaxxer movement. It's certainly playing a large role in it, but just simply kids and adults being under-vaccinated, or not at all. Ways that we talk about control the spread of disease, that's using cross-transmission, or reducing cross-transmission of organisms, infection control policies. One of the big easy things we can do, teach kids to wash their hands after they cough, they sneeze, definitely before eating, after using the bathroom. Those are going to reduce some of that cross-transmission. Especially with girls, teaching them to wipe from front to back when defecating or voiding. And teaching parents to wash abrasions and cuts before they bandage them to make sure we're washing out any organism that could be living there. Our first communicable disease we're going to talk about, and that's part of the viral infections. The first one we're talking about is rubella, or sometimes referred to as the German measles. For testing purposes, you do need to know it by rubella, because that is the technical name for it, or the medical name for it. So know it, and I will refer to it on test questions as rubella. So rubella is often called, again, the German measles, or sometimes you might have heard the 3-day measles. We have the 3-day measles and the 5-day measles. So the 3-day measles is rubella. Our causative agent is the Rubella virus, Rubella virus. It's spread by direct or indirect contact with droplets. Our incubation period. And remember, go back and review. What's the incubation period? Incubation period is that time from when the invasion of the organism occurs and the onset of symptoms, usually kind of your generic symptoms. So incubation period is usually about 14 days. Could be anywhere between 12 to 23, but generally about 14 days. The communicability period. Communicability means the time that they're able to spread it to someone else. Is 7 days before to approximately 7 days after the rash appears. The rash appears. Immunity. If you contract the disease, it offers lasting natural immunity. Of course, really, we don't want kids getting rubella. We give them artificial immunity, and the way we do that is by using the MMR vaccine. If you don't know what MMR vaccine stands for, it's for measles, mumps, rubella vaccine. So your clinical manifestations that you're going to see, one of the things that will set it apart from Rubiola, which is the next one we'll talk about, which is the Measles virus, one of the big differences in manifestations is the type of fever that they have. With rubella, they have a low-grade fever. They can have headache, malaise. One of the other big ones, they have lymphadenopathy. Typically, you will see the suboccipital postauricular, which if you look at the middle picture of this slide, that's what that is showing. They can also have anorexia, mild conjunctivitis, some upper respiratory symptoms. So if you kind of think about it, it's all kind of respiratory related kind of symptoms or very general symptoms. What will set this apart is the rash. They have a very distinct or discrete pink-red maculopapular rash, like you can see in the picture. It begins on the face and it will spread down the trunk and the extremities, and it will disappear on the 3rd day, hence why it's called the 3-day measles. They can also have arthritis with effusion in some children, so that's a big one that will set it apart as well compared to general measles. One of the things we worry about complication-wise is congenital rubella syndrome, which is from the transmission from mother to baby while she's pregnant. So we take a lot of precautions when we have pregnant caregivers or a child who has rubella and who's caring for them. We wouldn't want mom who's pregnant caring for this child because of the congenital rubella syndrome that can occur. It has tetragenic effects on the fetus. Other complications, again, arthralgia and arthritis are common complications that we see with rubella. Our therapeutic management, a lot of it is comfort measures. We can give them an antipyretic for their fever or joint pain. Typically, again, that fever is low grade, so you shouldn't need it, too much because it is a low grade fever. But if they've got some joint pain or if the fever is really causing some discomfort, we can just give them an antipyretic for that. Skin care, because of that rash, is important. If they were to be hospitalized during the time that they have rubella, we would want them in droplet precautions for 7 days after the onset of the rash, in addition to just our typical standard precautions. And of course, the big one, isolate the child from a pregnant woman, again, because of the tetragenic effects on the fetus. And again, how do we prevent this, or try to prevent this, is use of the MMR vaccine. All right, now we're going to talk about measles virus, or rubiola. I will refer to it as rubiola. It is often called also the 5-day measles. So the agent that causes it is the measles virus. Transmission, again, is with direct contact with droplets or by airborne spread. And incubation period is from 8 to 12 days from the time of exposure to the onset of symptoms, which is usually around 7 to 21 days. Communicability is 4 days before the rash to 4 days after the rash appears. So again, communicability is the time that they can spread it to someone else. Immunity, contracting the disease itself does offer lasting natural immunity. However, we usually provide artificial immunity. We do that by giving the attenuated live measles vaccine, which is part of the MMR vaccine. So your clinical manifestations you're going to see with Rubiola. They have what's called the 3 C's: cough, chorea, which is your clear nasal drainage, and conjunctivitis. The rash will help set it apart compared to rubella. With Rubiola, the rash again is a maculopapular rash. It's erythematous as well, and it usually starts behind the ear and spreads to the feet over 3 to 6 days. It will eventually turn from red to brown with disquamination over a few days. So when the rash is red, it fades with pressure. When the rash is brown, it does not fade. So if you kind of just pushed on where the rash is, when it's red, it will fade. When it is brown, it does not. And again, after about 5 to 6 days, that rash fades away. So hence why it's called the 5-day measles. One of the other things that sets it apart from rubella is what's called Coplic Spots or Coplic Spots. They are small white spots with a bluish white center, and they have erythematous background, typically seen on the buccal mucosa. As you can see some examples in the picture of the slide I gave you. During the prodromal period, again, one of the other things that will help set it apart is they typically have a high-grade fever of 103 to 104. High-grade fever compared to rubella. Again, malaise, they can have some photophobia as well, enlarged lymph nodes, might have some mild GI symptoms. Kind of looks like they're developing a respiratory infection. But the symptoms will worsen, and then they will decrease at about 3 to 4 days after the appearance of that rash. Our therapeutic management for a child who has Rubiola is just, again, a lot of comfort measures. Skin care for the rash. We can do an antipyretic for the fever. If they're having a lot of excoriation from the nasal drainage, we can put like a lubricating jelly or an emollient kind of underneath their nose to protect their skin. We can give them a cough suppressant if the cough is really bothering them. Because of the photophobia, we can certainly dim lights or draw curtains to help with that as well. If they're hospitalized, they do need to be in airborne precautions, as well in addition to your standard precautions that we would be doing it for anyone. This slide is just really to show you just a quick little snapshot, fun little picture to show you the difference between Rubiola and Rubella. And the big things that kind of set it apart. If you really focus on between those two, because they are very similar in their symptoms, focus on the things that make it very different for each one. If you know what's similar, that's a good thing to have kind of in the back of your mind, but really help focus on the things that set it apart, because that will help you determine which type of viral disease we're talking about. The third one that's on here, we're not going to talk about that one. I just couldn't find a picture. A better picture that was just comparing and contrasting Rubiola and Rubella. Right, our last viral disease we're going to talk about, or communicable disease we're going to talk about, is the chickenpox, or Varicella Zoster. So our agent that causes it is the Varicella Zoster virus. The incubation period is from 10 to 21 days. It's a long time for an incubation period. And the communicability, the time that they could pass this on to someone else. The communicability is 1 day before the rash to 5 to 6 days after its appearance, when all of the lesions have crusted. So they are considered contagious until all of their lesions have crusted over. Transmission-wise, this is highly contagious. It's usually spread by direct or indirect contact of saliva or the open vesicles, the open lesions that they have. You might even remember having this as a kid, depending on how old you are. We do have a vaccine now for this. So again, when you think about immunity, contracting the disease itself offers lasting natural immunity to chickenpox. However, what do we usually see in older life that is related to the chickenpox that usually comes back? It's the same virus, the herpes zoster virus. That virus can be reactivated, and later they have herpes zoster or shingles that you typically see in the older adult. Okay? We can provide active artificial immunity by the attenuated live virus vaccine or the varicella zoster vaccine. We can also provide passive artificial immunity to children who are immunosuppressed with different diseases like HIV, leukemia, by treating them with corticosteroids because they're offered with the varicella zoster immune globulin if they've been exposed within 72 hours. That can certainly help prevent or modify the disease so it's not quite as serious for those children. So typically, nowadays, most kids should be getting the varicella zoster or the chickenpox vaccine. And just because they get the vaccine doesn't necessarily mean it will prevent the disease 100%. There is still a small chance that they can have a chickenpox outbreak with that vaccine. However, if they do, it's usually a lot less severe and it's not as long either. Your clinical manifestations that you're going to see with chickenpox. For those of you who've had chickenpox, you might kind of remember it. You tend to have what we call a rash, or these lesions that are all over the body. That rash is accompanied typically by a low-grade fever and malaise. The lesions of those are the varicella. They'll present and go through various stages, but they'll present as a macule, then as a papule, and a vesicle. And those can appear all at the same time. It typically starts on the trunk of the body and then progresses outward towards the arms, the face, legs as well. When the lesion is in its healing stage, it has a characteristic kind of black crust, so when it crusts over. And these lesions, they come up in crops, so you could have some that are crusted with brand new ones appearing as well. They could be in the various stages, the macule, the papule, vesicle, or the crust stage, all at the same time. And if you've had them and you remember having the chickenpox, probably what you remember most is how itchy you were. They are very itchy. They're very paralytic, which makes it sometimes a challenge because we worry about if kids are itching at them, the potential of opening those up, as well as those lesions becoming infected if we're not leaving, or they're not leaving them alone. So we take great care in trying to prevent them from scratching, as well as with trying to prevent them from scratching. The more scratching they do, the more likely they're going to have scars if they don't leave them alone. So they're very, very itchy. They are considered no longer contagious with chickenpox once all of the lesions have crusted. That's a big piece of it. All of the lesions have to be crusted before they are considered no longer contagious. So our therapeutic management for chickenpox or the varicella zoster virus is we want to prevent that scratching to reduce infection. So use of topical oatmeal-based creams with antihistamines. I remember as a kid using like the calamine lotion, so you had little pink dots all over your face or arms and legs. We can do an antipyretic to help reduce the fever, so Tylenol, ibuprofen, or I should say acetaminophen or ibuprofen. In the high-risk patients, those who are immunodeficient, we can give them acyclovir, but again, there's a certain window of time that you can do that. That can help reduce the number of lesions and shorten the course of the illness itself. If a child is hospitalized with chickenpox, we would put them in standard precautions along with airborne or contact precautions until all of those lesions are crusted. And they cannot return to school until all of the lesions are crusted, because again, it has to do with the communicability periods. All lesions must be crusted. Okay, next we're going to talk about the Epstein-Barr Virus or infectious mononucleosis, aka also called the kissing disease. Our causative agent is the Epstein-Barr virus. Incubation period in adults and children is usually 30 to 50 days, but in children that incubation period is shorter. Communicability is direct contact with saliva of those who are symptomatic or asymptomatic but are shedding the virus. Mode of transmission is typically direct contact and through blood transfusions as well. Immunity, most of the time one episode does give you lasting immunity, and there is no vaccine available to protect against this. Typically, who gets it? Usually your adolescents and young adults, because they're the ones who are kissing and sharing the saliva. Assessment-wise, usually following the incubation period, they'll develop prodromal symptoms, which are kind of your generic symptoms: fever, malaise, chills, and anorexia. And the common features you typically see with the Epstein-Barr virus is the cervical lymph nodes are firm and tender to touch. Swallowing is painful. You can see the last picture I have there. Look how swollen their tonsil beds are. Look how red the back of that throat is. You can imagine how painful that would be. Again, those tonsils are enlarged and reddened and covered with a thick white membrane. They'll often have petechiae that also appears on the palate as well. Diagnostically, we have to do a positive or get a positive monospot test. That can be done as an earlier diagnosis. We can also draw blood, and we can look for antibodies against the Epstein-Barr virus in the bloodstream. That'll give us our final confirmation. Therapeutic management, it's mostly about treating the pain and the fever. So acetaminophen or a non-steroidal anti-inflammatory agent is helpful. We want to encourage rest because they're usually very fatigued. All contact sports should be avoided for at least 4 weeks after the onset of the infection, and it can take up to 3 months for the child to return to his or her baseline. Diet counseling, just make sure they're taking in an adequate amount of fluid. So we want good fluid intake. Even though they might have a sore throat, they really need to be drinking. And the best things to drink, things that are cool, non-acidic fluids, soft foods, things that aren't going to be irritating to that throat. And it just takes time for this to get over. So offer support, because a young adolescent is probably going to be a little frustrated just with the length of this illness. All right, let's move into bacterial infections. And the first bacterial infection we're going to talk about is impetigo. It is caused by the beta hemolytic streptococcus, group A, or staphylococcus, which also includes MRSA. Most common is probably your beta hemolytic streptococcus. Incubation is 7 to 10 days, and communicability is from the outbreak of the lesion until the lesion is healed. Transmission is with direct contact with that lesion, and immunity, there is no lasting immunity. Children can get repeated infections of impetigo. It's highly contagious. So assessment-wise, it involves the top layer or the epidermal layer of the skin, as you can see kind of in this picture I have on this slide, and it's generally characterized by this honey-colored crust with local erythema, most commonly found on the face and extremities, and it's very itchy. That's probably one of the other big common ones. It does tend to heal, even though from looking at this picture you would think there's no way this would heal without scarring. It does tend to heal without scarring as long as no secondary infection has occurred at the site. That's probably one of the biggest things we're worried about, the secondary infections, because of the main group it occurs in. They tend not to leave things alone. They're constantly picking at stuff. They don't have the cleanest hands and nails, so we worry about those secondary infections occurring. Sometimes you can see this as a secondary infection with insect bites or with body piercings as well. Like I already said, it's highly contagious, spread very easily, and the most common age groups it occurs in is the toddler and preschooler. Toddler and preschooler. Think about it. They're not good hand washers. They don't keep their hands to themselves. They don't know what personal space is, and they're all about sharing things, including obviously different germs and organisms, right? So we're trying to teach this age group really about good hand washing and leaving things alone. But with that age group, this is the reason why we're most concerned about secondary infections occurring. Right? Our therapeutic management, typically as long as it's a localized disease, meaning kind of like what's in this picture on this slide, it can just be treated with, I'm going to give you the brand name because it's easier to say, Bactroban for 7 to 10 days. There are other treatments, but Bactroban is the most common. And if it's a more extensive case, then sometimes we need to do oral antibiotics, but we try not to. Oral antibiotics are usually for the extensive type of cases of impetigo, and if we gave an oral antibiotic, it would be penicillin. Because again, think about what your cause is. The beta hemolytic streptococcus will respond to penicillin antibiotics. We want to teach parents to wash the crust daily with just soap and water, nothing too harsh, just a mild soap, and kind of soak them if they've got like that honey colored crust. We don't want them picking it off. We don't want them like really scrubbing to get the crust off, but just kind of washing the area to keep it nice and clean. And of course, teaching good hand washing is really important. Teach good hand washing and cut those nails short, because again, those things are going to cut down on the risk of transmission as well as the risk of secondary infections. Couple complications that can occur from this, from having impetigo, is rheumatic fever and acute glomerulonephritis, both of which we will talk about later in this course. But again, it's because of the cause. So beta hemolytic streptococcus can lead to other complications if this is not treated properly. All right, let's talk about pertussis, or whooping cough. The causative agent or organism is Bordetella pertussis, and transmission can be direct or indirect contact. Incubation is anywhere from 5 to 21 days, and communicability is greatest in what they call the catarrhal or respiratory illness stage. Immunity, contracting the disease offers lasting natural immunity. We can provide artificial immunity. Usually, again, the active artificial immunity is through the pertussis vaccine, and that's given as part of what we call the Tdap or DTaP vaccine. We can do passive artificial immunity, and that's pertussis. The pertussis immune serum globulin can be given as well. We typically see this in the unimmunized child or the underimmunized. We've seen this come back as well as, and they're recommending that people also get boosters of the pertussis vaccine later in life. Assessment-wise, it usually manages itself in 3 steps. You don't necessarily need to know, like the names of the stages. I just want you to have kind of an understanding of what the progression looks like. So usually in the first stage, that catarrhal stage begins in the upper respiratory symptoms, usually mistaken as a common cold. That'll last for maybe a couple weeks, 1 to 2 weeks. Then they move into the paroxysmal stage, which that can last for 4 to 6 weeks. Their cough changes from mild to the paroxysmal, so they have these 5 to 10 short rapid coughs, followed by a rapid inspiration that causes that whoop sound, or the high-pitched crowing sound. And if you click on my little link for whooping cough in baby, you'll see an example of that as well. Children are in obvious distress when they're coughing. They may be cyanotic, red in the face. They're just not getting the oxygen that they need. They can't quite catch their breath. The nose may drain some very thick, tenacious mucus secretions. They may vomit after these paroxysmal attacks as well. And then they move into the convalescent stage, and that's where they gradually have the cessation of the coughing and the vomiting. So basically they're getting over it. Diagnosis, it is based on a lot of the very striking symptoms that they have. And children who are younger than 6 months, they may have an absence of that whoop of a cough, the whoop sound. The pertussis bacillus, I can't say it, the pertussis, it can be cultured from nasopharyngeal secretions, so basically doing a nasal swab, and they can see if it is pertussis or not. They can look at white blood cell count. The lymphocyte count is particularly high. Again, it's showing you the infection. Our therapeutic management, maintain them on bed rest, especially during the paroxysmal coughing until that subsides, secluding them from environmental factors that will just aggravate the cough, so like cigarette smoke, dust, avoiding strenuous exercise. With their nutrition, to address that, because of the coughing fits that they get in, they often need frequent small meals, Again, we don't want to tire them out with trying to do large meals, but we still want them to make sure they're getting adequate nutrition. May need antibiotics for 10 days. That can certainly shorten the period of communicability and shorten the duration of the symptoms. Put them in droplet precautions as well, especially for the first 5 days after the antibiotic has started. So quite some time that they need to remain, even with antibiotics, remain in isolation. And infants, they might need to be admitted for observation, again, because they can become dehydrated, or the thick secretions can certainly obstruct their airway, and they may need airway management. You can see the complications, and prevention is the Pertussis vaccine, typically at 2 months. Again, it's called the DTaP, or it's part of the DTaP vaccine that they get it. Now we're going to move into our parasitic infections, which there's only one we're going to talk about, and that is Pediculosis Capitis, or head lice. It's very common, especially in the school age children. What you have, this is an example on this slide. I have multiple slides about head lice, but on this slide you can see this is just what an actual adult head louse looks like, or adult louse looks like. And the adult louse lives for only 48 hours. 48 hours without a human host. But the female louse, as long as she's got a human host, has a lifespan of 30 days. 30 days. The female will lay eggs, or what we call nits, at the base of the hair shaft. And those nits will hatch in about 7 to 10 days. The nits often have like this whitish oval speck adhering to the hair shaft, often mistaken for dandruff. However, if you try and just knock off the dandruff, if it's really dandruff, it'll come off really easily. If it is a nit, then it will not. It's very hard to get those off. You have to actually pull the nits off the hair shaft themselves, so they don't come off very easily. The lice themselves tend to have a grayish or tan color, despite what many people think. They do not have wings, so they do not fly, and the lice are often visible to the naked eye when you start looking through the hair. This slide is just showing you when you have that casing of where the nit is on the hair shaft, what it looks like. Picture A is actually an empty nit case, meaning the nit has actually hatched, where picture B is the nit is still intact and it's encasing and it has not hatched yet, which is where you get more of that whitish opaque look, where it kind of looks like dandruff on the hair. This picture is just showing an active case of lice. These are nits that have actually hatched. They're not the adult size, but you can see the little blackish specks. Because the child has lighter or blonde hair, it's easier to see those the lice when they've hatched. But these are probably still kind of small, haven't actually fully grown. If you had a child who had darker hair, probably be a little bit harder to see these, but the nits would show up a lot easier, because with dark hair you're going to see that white little nit with the casing around it. The clinical manifestations that they do have, lots of itching. So if you notice kids itching their head, they should probably be checked out, just in case. Again, the nits are often observable on the hair shaft themselves. They do look like dandruff oftentimes. Our treatment for head lice, we can use what's called pediculides. Most commonly that you've probably heard is Nix or Rid. They're just over-the-counter treatments you can get at any drugstore. The big thing is making sure that our family follows the instructions per whatever the box is of the type of treatment they get. besides doing the pediculides, they also need to actually do removal of the nits themselves. So there's different types of treatments out there. There's some that will take care of just live lice. There are some that will take care of the nits and any live infestation of lice. And there are some that are just meant for just the egg or the nit itself. Parents really need to read what a type of treatment it is. Most of the pediculides are aimed at a live infestation, which means it's not going to get the nits that are still in the encasing that haven't hatched yet. So important that they are reading the box, following the instructions. They may need to do a repeat treatment in a few days, usually about a week, so that they can get any that haven't hatched, that hatch later. But that's why it's so important also to teach parents to do removal of the nits themselves, which that needs to be daily for at least 2 to 3 days, even with treatment, because we're trying to prevent spread and reoccurrence. Because if they don't remove the nits themselves when they hatch, then we just have a whole new reinfestation of lice. Lots of education needs to go into teaching the family about what to do. Anyone can get lice. Often people tend to think of, I feel really dirty, or they must come from a dirty home because they have lice. That's not true. Lice can happen in any socioeconomic level, so anyone can get them. The louse, which is the adult lice themselves, they do not jump, they do not fly. They have to actually crawl on to someone's head in order to get them. And again, you have to think about, because they can live without a human host for 48 hours, so they can live on furniture. You go to the movie theaters, if it's got fabric type of, it doesn't even have to be fabric. You go to movie theaters that's got the high back seats. If someone before you had lice and you sit down and it's on that chair and you're laying back watching your movie, eating your popcorn, all that little lice has to do, or louse has to do, is crawl in. Again, they just have to find a human host within that 48-hour time frame. Which, with that being said, why it's so important, and again, thinking about the age group who gets this, the early school age, what do they like to do? They like to share items, don't they? Personal items. So, caution against sharing against combs, hats, scarves, hair ornaments. Girls are notorious for this, for liking to share those different kind of items. Lice are not carried or transmitted by pets, so your pet in the home cannot get these and give them to anyone else. Important, again, like I said, make sure family treats according to the package label, whatever it is, type of treatment they got. And I already talked about this. Lice live for 48 hours away from a host, but the nits are shed into the environment, and those that are shed into the environment, so just think about, because most commonly girls and boys get this, but probably more commonly than girls, because again, they're the ones sharing things more often than boys do. But say they got long hair, and some of that hair just naturally, you shed hair into the environment, right? Or brushing their hair comes out. Well, those nits that are on that hair that has been shed into the environment are still capable of hatching in 7 to 10 days. So there's lots of care that has to go around treating the home itself. We want to machine wash all washables and dry in a hot dryer for at least 20 minutes. The idea is you want hot water, hot temperature in the dryer, because that's going to help suffocate them and dry out any nits that may be present. We want to vacuum the carpets, car seats, pillows, stuffed animals, mattresses, furniture, as much as you can to get any of that hair that's been shed into the environment. Things that cannot be washed in the laundry, so thinking about like pillows, again, stuffed animals, things like that. You need to seal them into a tightly sealed bag, so just put them in a garbage bag, tie them up for 14 days. Why 14 days? Well, think about it. If you have a nit, say it doesn't hatch till day 10, it can then live 48 hours without a host. That puts you at day 12. You want to make sure you're getting beyond that time that it can survive. So 14 days, seal everything up for 14 days, and being sealed in that plastic bag, basically it suffocates them, and then once the 14 days are up, they can have their stuffed animal or pillow back. Anything else like combs and hairbrushes, hair accessories, We want to soak them in a lice-killing product for 1 hour, or if it's able to be boiled, we can boil it in water for 10 minutes. So lice-killing product for 1 hour or boiling water for 10 minutes. Really important, again, inspect any children who seem to be scratching their head a lot and checking them for lice so they can be treated properly. Moving into fungal infections. Fungal infections are superficial infections that live on the skin. One we're going to talk about is ringworm. 2 different types of ringworm we're going to talk about, and that's Tinea capitis, which is ringworm of the scalp, and Tinea corporis, which is ringworm of the body. Transmission-wise, ringworm can be transmitted from person to person, or it can be animal to person. So your pets can have this and pass it on to you or other children. So the pictures on this slide, there's picture A is your Tinea capitis. It's probably the worst case ever of ringworm of the scalp. And then the second picture, picture B, it would be Tinea corporis, which is ringworm of the body, which is typically what you're probably more used to seeing. And then the next slide, I'll talk about the care of each one of these. All right, with Tinea capitis, which in this first picture is probably more commonly what you might be accustomed to seeing with ringworm of the scalp. It is lesions in the scalp, can extend to the hairline or the neck. The characteristic findings usually scaly. They have this circumscribed patch or patchy scaly area. Oftentimes in that area you have alopecia, so the hair is missing, and it's very itchy, so pruritic. Management of Tinea capitis, oftentimes we can give them what's called oral greasefulvin, or I'm totally going to flubber on this generic name, but turbinafine or Lamisil can be given. We can use a topical shampoo. Selenium sulfide is the appropriate type of shampoo to use. There's the Nizoral shampoo or the Loperox shampoo. The big thing is making sure it's the appropriate type of medicated shampoo to treat the fungal infection. As well as we can give topical antifungal medication like the clotrimazole. With Tinea corporis, so Tinea corporis, again, ringworm of the body, usually it's kind of round or oval, erythematous, scaly patch that spreads peripherally and clears centrally. Spreads peripherally and clears centrally. It can involve the nails as well. Management for Tinea corporis, we can do a topical antifungal like tolfenate or the clotrimazole. Usually they need to continue to apply that for 1 to 2 weeks even after there's no signs of the lesion to make sure they have properly treated it. So even though there may not be any signs of the lesion, it looks like it's all gone, they should continue to treat for 1 to 2 weeks. Some general nursing care reminders about ringworm, teaching parents how to care for ringworm to avoid the spread of infection to others in the house or to friends of the family or the child. Making sure we use appropriate hand hygiene. We don't want children sharing or exchanging any kind of grooming items. And you got to think about other sources of infection: headrest, helmets, public transportation, gymnasium mats. Right? We tend to think of, especially like for boys who are wrestling, ringworm with gym mats, but not just that. What about girls who are taking gymnastics? If those things aren't clean, and how often are they? Let's face it, ringworm's a possibility. The big thing is we want to keep the child from touching the affected area. Use of distraction, especially if it's a younger child, we may need to use some distraction to keep them from doing that. And teaching parents how to apply topical medications and for how long, and if they're going to do oral medications, how often they need to do it, and for how long. Alright, Candidus, caused by the Candida albicans fungus, is responsible for your congenital infections. It can cause typically what we see in children. We can have Candida vaginitis, especially in adolescent females, or one of the other common ones we see in children is oral candidus, or what we call thrush, especially in the newborn, and that is caused from exposure at birth. Typically characterized by white plaques on an erythematous base in the buccal membrane and surface of the tongue. Often looks like milk curd that's left from a recent milk feeding. However, unlike milk curds, the thrush plaques don't scrape away easily, or don't scrape away at all, I should say. It can leave the infant's mouth painful, making it difficult to nurse, whether breastfeeding or bottle, especially breastfeeding. It's easier to feed from a bottle, but it can still be very painful to the point where they may not suck well on breast or bottle because of the inflammation and the pain that's caused. On the skin, like in this picture that I have on my slide, it causes a severe bright red, sharply circumscribed rash, most commonly in the diaper area. So it has intense color, can have sometimes some satellite lesions can be present as well. Oftentimes, and you'll see some of the examples in the next couple of slides, oftentimes people think this is just diaper rash because it's just red and irritated. However, the difference is it doesn't respond to your usual diaper rash measures of applying a protective ointment, doing frequent diaper changing, making sure we allow plenty of air, making sure that they're dry. It won't clear up. And that's because we have a fungal infection that's present. So the only way to treat that is to treat it properly with an antifungal. So our therapeutic management, most common drug that we use, nystatin, for both the oral Capitus as well as for the diaper rash Capitus. It's just a matter of which form that we prescribe it in and how it's given. So for oral Capitus, it is administered orally about 4 times a day. Important to teach parents to just drop the liquid into their mouth after they've eaten, so that it remains in contact with the lesions. If they did it right before they did a feeding, the feeding would wash it away and it wouldn't clear up. So it's important to make sure they do it after a feeding. For diaper rash, we can just use nystatin ointment. We would want to teach the family, make sure they're removing soiled diapers as soon as possible, so frequent changing of soiled diapers. Clean any urine in the perineal area with a non-irritating cleanser. So even the commercial baby wipes, those are irritating oftentimes because they've got alcohol in them, fragrance in them, that just irritates the skin further. Simply just wet washcloth, warm water, just to kind of clean that skin. Keep them as dry and clean as possible. Again, the frequent diaper changes, exposing them to air. So don't just like clean them off and slap another diaper on, making sure that their skin really is dry, because if you're not drying them off or letting them kind of be exposed to air, all you're doing is locking in more moisture, which is just going to further irritate any of the diaper rash and Capitus that they may have present. Apply a skin barrier cream like zinc oxide. You don't wash it off with each diaper change. That's the whole point, is it's protecting the skin. So you just get the worst, if they've pooped and it's kind of poopy, then just take off like the top layer. You don't want to scrub it off. You want to leave as much of that skin barrier in place, because that's its whole job, is to protect the skin. And then of course use of the prescribed nystatin ointment as well. All right, and moving into the last part of, and the remainder of our integumentary disease notes, is talking about thermal injuries or burns. Burns or injuries to the body tissue are caused by typically excessive heat, so greater than 104 degrees Fahrenheit. You can get it from more than just heat. There's all different types. There's chemical burns, there's electrical burns, inhalation injuries. So there's more than just thinking about the typical thermal injury or burn injury. Second greatest cause of unintentional injury in children ages 1 to 4. And that's because younger children are most at risk for the scald burns from hot liquids and steam. So that's why, especially like bath temperatures, turning pot handles away from on the stove so that they can't get hold of them are really important. Third greatest cause, burns are third greatest cause in children from ages 5 to 14 years of age. And for older kids, oftentimes they get burned from flames due to campfires, heaters, or fireplaces, touching a hot curling iron, playing with matches or lighted candles. You can have eye burns or from splashed chemicals, from doing home projects or science experiments, maybe in school, things like that. Always important to keep in mind when evaluating a burn, particularly scalding, it can be caused by maltreatment. We've kind of already talked about that. Oftentimes they're very distinctive marks, especially with maltreatment cases. They have very distinct lines, oftentimes where you can see where they've been dipped into maybe hot water. It's often symmetrical, especially if you think about feet being dunked into a tub of hot water. So you do have to kind of look at what does it look like and keep that in the back of your mind as well. Burn injuries, they tend to be more serious in children than adults because the same size burn covers a larger surface area in a child. So when you think about total body surface area in a child, the burn size itself may be similar, but it's covering more of the child's body. Alright, thinking about burn prevention tips for parents, that should include some of these things we've already talked about with injury prevention and growth and development. Others we may not have, but installing smoke alarms in the home on every floor, near rooms, especially where family members are sleeping. Maintaining those smoke alarms with testing, ideally monthly, to make sure they're working properly, using those long life batteries. Creating a family fire escape plan. Involve children in the planning and the practice frequently. Teach them how to stop, drop, and roll, how to feel a door if it's hot, how to crawl if there's smoke, where to meet, where's your meeting place as a family if something would happen. Never leave food unattended on a stove, in the oven, or microwave, especially with children around. They're curious, they're hungry, they want their food, right? So don't leave them unattended. Check the water heater temperature. Make sure the thermostat is set to 120 degrees Fahrenheit or lower. And adults should always be testing the water before children enter the bathtub or the shower because they are not able to regulate that well. Assessment of burns. Typically, children who have a burn injury are brought to a healthcare facility, and there's lots of questions that are asked about where the burn is, what the extent and depth of the burn may be. So it's important to assess and document the location of the burn. Face and throat burns are particularly hazardous because we worry about what we can't see, the unseen burn in the respiratory tract. We worry about it leading to respiratory tract obstruction. Hand burns can certainly lead to adhesions, which could later eventually inhibit full range of motion, especially if there's improper positioning that occurs while things are healing. Burns of the feet carry a high risk for secondary infections. Typically, when we are assessing a burn and trying to figure out how much of the body was burned, so talking about total body surface area, we tend to use what's called the rule of nines. You've probably heard it before in adult med surg, not any different. However, again, our rule of nines adds up a lot quicker compared to the adult. So it is very useful. Sometimes though they do say it doesn't always apply in children just because of body proportions. You can see by this chart what the proportion difference would be and what those burn percentages would be like. You are not going to have to calculate a total body surface area for a burn. That was Med-Surg 3. I just want you to understand there's different ways that we do assess the burn, but I'm not going to have you calculate that. That's what Complex was for. If you haven't gotten there, you will when you go to that course. Important to make sure when you are assessing that we do undress children completely so we can inspect their entire body when there is a burn present. Ask what caused the burn, because different materials cause different types and cause different degrees of burn. Hot water is typically referred to as a scald burn. If there was a fire that happened, want to know, was it in a closed space? Because if it was in a closed space and the child was in that closed space, they're more prone to respiratory involvement compared to an open area where a burn may be. Alright, depth of injury. It's what we use when estimating the depth of a burn. We use the appearance of the burn and the sensitivity of the area to the pain, or to the area of pain, as criteria. So you'll hear them referred to as different ways. Sometimes you hear them referred to as first degree, second degree, third degree, or in fourth degree, as well as we also can categorize it into partial thickness burns, which are your first and second degree burns, and your full thickness burns, which are considered your third and fourth degree. You can see that chart I have in there on page 13 of your notes. This should really be a review. I do expect you to know this. This will be part of your quiz, as well as the assessment piece, and talking about your depth of injury and causes of burns will be part of your next quiz in class. So you need to review this. This should be review. You've covered this before in previous med-surg. It's not any different than kids. So definitely take a look at that and know your differences, whether it be first degree, second degree, third degree, and what that involves, what it looks like. Let's talk about what the therapeutic management looks like for a burn. And depending on how severe that burn is, the care might look a little bit differently. But in general, before anything can be done, depending on the depth of that injury, we have to worry about what the emergency care looks like. And when we refer to emergency care, it's really getting at stopping that burning process. How do we stop that burning process? Well, if it's someone who, say the child's clothes catches on fire from getting too close to the fireplace or a bonfire, you would want to place that child in a horizontal position and roll him or her in a blanket to extinguish those flames. We also want to teach children to never run if their clothing catches on fire. It's best to do what? We teach them that stop, drop, and roll method, right? But kids panic, so it's important to practice those even when we're not in an emergency setting, so that they don't panic in that situation and take off running, because that's just going to spread the flames further. Once the flames are out, we want to remove any burned clothing and jewelry. Reason being is we want to remove as much of that as possible, because that holds heat. Even though the flames are out, it's holding heat, which means we're still continuing to burn into the various layers of our skin, and we want to stop that. So you got to think about whether it be clothing, whether it be a watch, a bracelet, metal, plastic beads, all of that holds heat. Even though flames are out, we want to stop that burning process. So we want to remove as much of that as possible. You don't want to open any blisters. Why not? Well, because of infection purposes, right? So leave any blisters alone. Leave them intact. Don't apply anything to the wound. Although if you think about it, think about the depth of the injury. Sometimes just air movement can be painful for someone who's got a severe burn. We would want to cover them with a clean cloth, with a clean sheet, ideally, just to prevent that, right? But we don't want to apply any kind of ointments or bandages to the wound itself. They need to be taken to a burn treatment center, which here in our state for children, we do have one at Riley, but they need to be taken to a burn treatment center where they can assess them and treat them properly. So then we break it down into, besides the emergency care, minor burns, moderate burns, and severe burns. With a minor burn, again, you want to stop that burning process. So part of that is immediately apply cool or tepid water to help cool the skin and prevent further burning. If any blisters do show up, leave those blisters intact. And then when they're at a burn center or somewhere where they can be treated, they typically apply an analgesic antibiotic ointment and a gauze bandage to prevent any infection, especially if there's any blisters that do open up. That will help with that as well. Pain management is a huge consideration to take because they do tend to have a lot of pain with these minor burns. Important to educate parents about follow-up appointment, usually in about 2 days. That's so that they can change that dressing, inspect the area for any signs of a secondary infection. In the meantime, we want to make sure parents are keeping that dressing dry, not just in the time it takes them to come back for follow-up, but even afterwards. So no swimming and no getting the area wet while bathing until that burn has healed. And that, with a minor burn, usually takes about 1 week. With moderate burns, again, all the same things still to a certain extent apply. We want to stop that burning process. If they would have any blisters, we don't want to rupture them. The reason we don't want to open those up is because it would put them at risk for what? Put them at risk for infection, right? And we don't want to open up any other sources of infection. So if they do have broken blisters, oftentimes they'll debride those, remove any possible necrotic tissue as that burn heals as well. They will cover the burn with a topical antibiotic. Most commonly, silver sulfidine is used, and then they'll place a bulky dressing over the burn site to help prevent any damage to it and for it to begin healing. And usually, if they don't stay overnight in the hospital, they're asked to return within 24 hours, and that's to help assess pain control, assess the burn site itself for any signs and symptoms of infection. With a severe burn, and when they're critically injured, it does require immediate care. They need all kinds of things. Some things that can include is fluid therapy, systemic therapy, pain management, and physical therapy. With our goal is we want to prevent disability from scarring and infection and contractures. This portion of therapeutic management and nursing care is really aimed at the child who comes into a burn center with a severe burn. Okay, so the rest of this is going to be aimed at severe burn care management. So one of the big things we worry about, once we've stopped the burning process, the flames are out, we've removed clothing, we've covered them with a sheet. The next thing that we're most worried about is their airway. We want to maintain a patent airway and ventilation. We're always assessing for airway compromise. We can provide humidified oxygen as needed. It's important to make sure we're assessing airways with flame burns. Part of that, because those are the hidden injuries we can't see, right? Inhalation injuries. Look for singed nares, eyebrows. Those certainly give us clues as to the possibility of having an airway injury that we can't see. We want to keep the child calm because we want to keep and conserve their energy, try and decrease their anxiety. Their body's going to get thrown into a shock phase where it's going to be using a lot of energy, so we don't want them burning up any of their energy just from being anxious and scared. We want to try very hard to keep them as calm as can be. Besides maintaining airway, the next thing we're most worried about is fluid replacement and resuscitation. If they don't already have an IV access from emergency personnel bringing them in, we would need to obtain IV access. And the IV access is to help maintain cardiac output. Yes, we're resuscitating their fluid, but we're maintaining cardiac output. And by maintaining cardiac output, that means we're going to preserve renal function. So those things are huge when we're talking about a severe burn. Maintaining cardiac output and preserving renal function. Because they have an increased permeability of their capillaries, they have a rapid fluid and electrolyte shift. That's what they're going into that shock phase. Usually within the first 6 hours, and it will continue for the first 24 hours. When they go into that shock phase, and losing all those fluids and electrolytes, that's what gets them into hypovolemia, hypoproteinemia, hyponatremia, and hyperkalemia. Most important things we're going to give them with the type of fluid we're going to give them is usually lactated ringers or normal saline. for their fluid replacement. That can help replace plasma replacement. It gives a source of glucose, especially if we have 5% glucose in the water, to help maintain our glucose levels. You would never administer potassium as an additive immediately after a burn until you have evaluated kidney function. Again, that's why it's so important to get IV access, maintain cardiac output, so that we can preserve renal function. Well, how do you know that their kidneys are functioning? Well, we need to monitor for renal failure. Basically, one of the big things we're looking at is, do they have urine output? Urine output should remain greater than 1 ml per kilogram of body weight per hour. Right? We can monitor their specific gravity to determine if their kidneys are able to concentrate urine to conserve body fluid. Oftentimes we'll put a Foley in place so that we can get an accurate measurement, and we can send specific gravity off to have it tested. Right? So maintaining cardiac output, preserving renal function is huge, right? Because of that fluid shift. Again, what happens to all our fluids? It's third spacing, which means if we don't have enough in our circulatory system, we're not perfusing our organs. So maintaining that cardiac output to perfuse our organs, specifically looking at the kidneys and monitoring for renal failure, is really important. Next, we want to look at nutrition. Because they go into an increased metabolic rate, and with that shock phase, they are going to have an increased need for protein and calories to meet the metabolic demands that are occurring. And that's to help also prevent catabolism and hypoglycemia. So they have an increased need for protein and calories. Oftentimes we may need to give them supplemental IV or parenteral nutrition solutions, or even through a G-tube. They're going to need supplemental vitamins to help facilitate growth and prevent anemia, replace those depleted stores. In the beginning, we're not worried about nutrition aiding in the growth of new tissue. It's really about avoiding further protein breakdown, because with this increased metabolic need, if we're not providing enough protein, the body is going to find a source if we don't provide it, and we don't want that to happen, right? So we want to prevent further protein breakdown or getting into catabolism, right? So we need to make sure we're giving them the proper nutrition. Patients are often NPO, at least initially, and that's because of the risk for what's called a curling ulcer, or sometimes referred to as a stress ulcer. It causes the pH level of gastric secretions to increase, which leads to your curling ulcer. So oftentimes they are NPO, and we provide them parenteral nutrition. Managing pain is certainly a priority. Morphine is typically our drug of choice. We often use it with dressing changes, debridements. They can have a PCA or maybe have some conscious sedation done with those debridements. But morphine is typically our kind of go-to med for pain management. And then we want to look at the wound management, right? Wound management becomes our priority after we get past the shock phase. It's always kind of in the back of our mind, but we got to take care of, when they first come in, we got to take care of what's happening in the shock phase, and then we turn our attention to really managing the wound. Infection is a major complication that we see with burns. We want to reduce the risk for infection with a severe burn. Oftentimes we'll use different antibiotics to prevent infections. They can give them the tetanus toxoid to prevent tetanus from occurring. So maybe giving them, if they need it, the tetanus booster that we often, or maybe if it's not a booster, but giving them the tetanus shot as well. We often are doing nose, throat, and wound cultures, especially it's done immediately, and then sometimes even on a daily basis, and that's just to detect any sort of organisms that might be occurring so we can properly treat them early on. Any equipment that's used at the burn site has to be sterile to avoid introducing infection. We would put the child on sterile sheets in a private room trying to reduce the possibility of infection, and personnel pretty much wears head-to-toe coverage, caps, masks, gloves, gowns, just to prevent the possibility of infection of their wounds. Right. Therapy for their burns. Second and third degree burns may receive various types of treatment. There's what's considered open treatment, which the burn area is exposed to air. And then there's also what's referred to as closed treatment, where the burn area is covered with an antibacterial cream and lots and layers of gauze. You can see in the little chart I gave you on page 15 of your notes the description of open versus closed and what the advantages and disadvantages are by using those treatment methods. Most times with severe burns, a burn dressing is applied loosely for the first 24 hours, and that's to prevent any sort of interference with circulation, because we know with the shock phase and how much fluid they're losing that there's going to be edema that forms. And so by wrapping that dressing loosely, it allows for that edema to occur without cutting off any sort of circulation. Also important to not allow too burned body surface areas to touch, because we worry about webbing. So you can see, like in the one picture of the hand, where they have a dressing around each individual finger, and then so you wouldn't want the two fingers touching, because then you worry about what's called webbing or to occur as things heal. You also don't want to use adhesive tape or an anchor dressing to skin, because it can be painful to remove, certainly leave excoriated areas. It just leads to another additional site, if it becomes excoriated, an entry site for infection. Oftentimes what we'll use is netting to hold a dressing in place, because it also allows for that easy expansion of the burn area. There's different types of treatment as well that we use. There's topical therapy. With the topical therapy, the biggest one that drug of choice that they like to use is the silver solvadine or Silvadine, and that helps limit the infection at the burn site. It's usually just applied straight to the burn as a paste, and then it's covered with a few layers of some mesh gauze and wrapped up. Oftentimes we also need to do debridement, and debridement part of that can be removal of necrotic tissue that can be occurring. Debridement can happen simply at the bedside. They can do it as part of during hydrotherapy as well. There's lots of different ways to do it. They can be done using the collagenase, which is an enzyme that dissolves devitalized tissue. Manual debridement, oftentimes done with hydrotherapy. It helps loosen any eschar tissue that may be there. Debridement can be a very painful procedure, so it's important to certainly medicate them and take care of their pain, and use of distraction can be helpful as well. And then we get into grafting, and I am not, for testing purposes, I am not going to ask about the different types of grafts. I just want you to be aware that as we get past the acute phase and we get into the healing, grafting is a method that we do use. There's a couple different pictures in the next few slides of the different grafts, but we can have the allografting, which is skin that comes from a cadaver or a donor onto the clean burn site, or we can have autografting, which is where a layer of skin from both the epidermis and part of the dermis is removed from an unburned portion of the child's body and then placed over a burn site. You do have to take a lot of caution and care with a burn area as well as the donor site itself. It needs to be covered with a gauze dressing. You don't remove it or change the dressing unless ordered to do so, and the big thing is observing for infection. Your different types of grafts that can be done, there's full thickness skin grafts, which is an actual sheet of skin that is removed. It's usually more common to be used for facial burns because of cosmetic purposes, where you have split thickness skin grafts that's taking a small portion of skin, and then we put it through what's called a dermatome, or I should say the mesher, because then it takes a top layer of skin, that's very thin, and the idea is then you're stretching it, and when you see the picture of the dermatome and the mesher, you send it through the mesher and it creates these little chevrons or diamonds, and it allows you to take this small piece of skin and stretch it for a larger area. However, that chevron diamond shape, when the skin heals, that shape stays. So it's not something you would want to be using like on the face or things that are exposed because of cosmetic purposes. It will heal the same way that it looks. Right, in this last slide, we're going to talk about the complications, which some of this we've already talked about a little bit, and we're kind of hit on a little bit, is getting in a little more in depth of severe burn injury, the type of complications that you can see. Not really any different than the adult complications you can have with a severe burn. So if you've been through complex med surg 3, this should kind of sound familiar. The immediate threat to life is certainly related to what, do you think? It's going to be related to airway compromise and shock. So you're blank, airway compromise and shock. We worry about inhalation injuries, whether it be from a direct thermal injury, so burns that occur to the face and the lips. We worry about what damage is happened to our airway that we can't see. It can be delayed even up to 24 to 48 hours. Typically what you'll find is you'll start having some wheezing, increased secretions, hoarseness, the wet rails. You might see some singed nasal hairs. They can develop laryngeal edema. This patient needs to be on 100% oxygen to help reverse those effects. We also worry about, with inhalation injuries, carbon monoxide injuries. These can take place in an enclosed area, and typically the findings will include mucosal erythema and edema, which will be followed by sloughing of the mucosa. These patients again require 100% oxygen to reverse the effects. Other complications, thinking about the renal system, we have an unremitting shock that we talked about, right? That fluid shift and the loss of fluid and electrolytes, right? That unremitting shock that we see is followed by renal shutdown, which is why fluid resuscitation is vital. Your BUN and creatinine are going to be elevated because again it's affecting the way kidneys are functioning. Usually you'll have an excess of potassium, especially during the first week. That's a big problem. And certainly if we have an excess of potassium, we worry about the cardiac effect it is having. Another complication you can see is anemia. Because of the direct heat destruction of the red blood cells, so those heated red blood cells lead to a hemoconcentration and related to your fluid loss and the decreased cardiac output. We have decreased cardiac output because, again, of that fluid loss, that unremitting shock that we're seeing in the acute phase. And then you have hemolysis of those injured red blood cells and trapping of the red blood cells in the microvascular, which can lead to thrombi. With the metabolism, we talked about how much more their metabolic state is increased. So the metabolism is greatly accelerated with rapid protein and lipid breakdown, which is why we're trying to prevent catabolism, leading to starvation. So that's why it's so important to provide the appropriate nutrition and protein to prevent this from happening. Because if we don't provide it, the body's going to find, usually from muscle and fat, it'll break down. Right? So metabolism is greatly accelerated. Our cardiac response, the complication with our cardiac response, we have an alteration in circulation. This is immediate, and it's what leads to burn shock and getting into decreased cardiac output. So alteration in circulation leading to your burn shock and leading to decreased cardiac output. So if we don't restore those fluids and do fluid resuscitation, we're going to have decreasing cardiac output, which means we're decreasing the perfusion to our organs, which will get us into organ dysfunction and death if we don't do something about it. We do use the Parkland formula just like they do in adults. I'm not going to have you calculate the Parkland formula. Again, that was part of complex med surg. I just want you to be aware that we do use the Parkland formula as well as in pediatrics. Complications with our labs. We have all kinds of effects that are going to happen with our labs. With our CBC, we're going to see decreased red blood cell count, again, because they're being destroyed from that heat. Hemoglobin, hematocrit are decreased as well. Electrolytes are decreased because we have that ongoing loss from the burn area, again, getting into that, which is why that fluid resuscitation is so important. Protein, again, we're going to have decreased protein breakdown because of the increased metabolism and metabolic need. BUN and creatinine are going to be increased because of tissue destruction, and especially if there is a presence of oliguria. And oliguria just means very little or no urine output. Or very little urine output. Wound cultures. We're constantly doing wound cultures. That's because we want to identify organisms as early as possible so we can treat those. More of a long-term effects that you're going to see are the last three things complication-wise. Oftentimes these kids have body image disturbance, so it's certainly important to address that. Ask them how they're adjusting, especially if they're going to follow-up visits. They may need some formal counseling to help rebuild self-image, but they do have oftentimes some, sometimes even lifelong body image disturbance. Growth and development. With a severe burn, you can have severe delays in growth up to 3 years after a major burn, and a major burn is considered more than 30% of the total body surface area. So it can certainly affect, again, because it's affecting our nutrition, the metabolism, and the way the body is using those things, it can certainly affect growth and development. And as one of the other long-term things that we'll see complication-wise is contractures and scarring. It's a major complication, which part of what we try and prevent is a lot of contractures, so effective use of rehab, trying to prevent those infections, doing range of motion exercises. Oftentimes they'll also, after the burn has healed, they'll do compression garments. One of the common ones that you hear is the Jobs garment, or compression sleeve type things, and that's to help minimize the scar tissue that can form. But again, with a major burn, it can take up to a year for that burned area to mature. So we really want to take precautions in preventing scarring and contractures so that they don't need more needed surgeries unneeded surgeries down the road, if we can prevent that.